Hello friends, welcome to UGC EPG Pathshala. I am Atika Tajdar from Department of Geography, Jamia Millia Islamia. I am presenting this module on behalf of Mr. Lakshman. Today, in this module, we are going to discuss about post-disaster relief and healthcare management. The learning objectives are post-disaster relief and the process. Disaster relief is the provision of assistance during or immediately after a disaster to meet the relief, preservation and basic subsistence need of the people affected by any disaster event. It can be of any immediate, short-term or protracted duration, but the provision of relief appropriate to the need of the community and to ensure last-mile connectivity is not a simple and straightforward activity. It involves multiple internet process and strategies. Based on the need and loss assessment, the material and service requirement are assessed and the procurement, transportation, warehousing and distribution of relief materials are planned and implemented. The flow of activity from procurement to distribution is governed by the principles of humanitarian logistics and supply chain management. This section will elaborate these processes associated with post-disaster relief provisioning. Let us discuss the relief cycle. The relief requirements in a post-disaster operation can be segregated into 4 distinct phases. First is assessment. This phase is carried out immediately after the disaster strike to identify and assess the immediate material and resource need of the affected people. During this phase, there is no significant movement of resources or material. Second, deployment. In the deployment phase, the relief reaching the affected area and the associated activities goes through a sudden spike and a ramping up of processes. Third, sustainment. During this phase, the relief reaching the affected area and the associated activities is sustained at a stable level. Fourth, reconfiguration. During this phase, the operations are reduced and the relief provided also reduces following a ramp down function and gradually terminated with the responding agency having fulfilled mandate or have ran out of resources. The relief cycle is observed in all relief operations and any organization responding to a disaster scenario will be following these phases. After the reconfiguration phase, depending on the development requirement, another similar cycle can start. But it is beyond the purview of this module. What is humanitarian supply chain? Commercially, supply chain is defined as the network of entities through which material flows. It consists of all activities associated with moving goods from the stage of raw material to the final stage where it reaches the end user. These activities include procurement and sourcing, production planning, production inventory or stock management, transportation or logistics, warehousing and storage, and customer service. The management of the entire process is called supply chain management. Supply chain in disaster specialize in organizing the procurement, transport, storage and delivery of required supplies in case of disaster to the affected people. Commercial supply chain are often disrupted after the disaster to fill the space while addressing the sudden spike in demand and probably the sudden shortage of supply. The formulation of a humanitarian supply chain focused toward alleviating the suffering of the disaster affected community is required. The objective is to address the demand and supply uncertainty and satisfy beneficiary requirement in a timely manner at an acceptable cost. The humanitarian supply chain differ from a commercial supply chain in the following aspects. Unpredictable and unstable demand from previously unknown locations. Usually, production phase is not considered in humanitarian supply chain. The cost of supply-demand gap is very high in the humanitarian supply chain, which is often life and death. Due to the involvement of multiple stakeholders and the ultimate motive of providing essentials to the affected community, there is a little performance measurement built in the system. The last one is variable level of enabling technology, especially if the operations are from a developed nation organization working in developing underdeveloped nation. Now, disaster relief network. The following diagram represents a typical disaster relief chain configuration. Disaster relief network shows the flow of goods from the source to the beneficiaries in a humanitarian relief operation. Based on the post-disaster rapid assessments, the supply of relief in the disaster-affected area is initiated. The prepositioned material, which is materials strategically stored in a certain pre-planned location for ready utilization in case of contingencies or disasters, are mobilized, while material which need to be procured from local and global sources, they could also be the supply of donated items in response to the appeals from various forums. All these materials are collected and transported to distribution centers. This section of the supply chain is known as the supply acquisition or procurement phase. From the distribution centers, prepositioned material as well as material received as donation are transported to the intermediary stocking and distribution points. This section is thus linked with prepositioning and warehousing of the relief materials. Often, the ports and principal transport terminals serve intermediary stocking and distribution points. From the intermediary stocking and distribution points, the relief is moved to the local distribution points, which are often located very close to the affected area but not in the close vicinity of the affected area. Depending on the nature and scale of disasters, the location of the distribution point varies. From the local distribution point, the relief is moved to the beneficiaries located in the affected area, which is often termed as the last mile. This composes the last mile distribution component. The transportation component link all the sections together. First, the procured material are transported to the distribution center, and then from distribution center they are taken to the distribution point and finally to the beneficiaries. Fleet management in relief scenarios plays a significant role in deciding the effectiveness of the relief program. Depending on the contextual requirements, the mode of transportation and other parameters are also determined. The configuration is highly dynamic and often one or few of the components might not exist in the configuration or certain components might get appended. International best practices. The emergency products to be supplied in a post-disaster scenario largely depend upon the type of disaster and context of the affected region. There are multiple categorizations to identify the product set to be supplied in a disaster-affected regions. One of them is IFRC Emergency Item Catalog. The International Federation of Red Cross and Red Crescent Society and the International Committee of the Red Cross, supported by National Society, have coordinated joint efforts toward the need for improved standardization of emergency relief and medical items. This harmonization has been due to their experience over the years of responding to emergency situations across the globe. The IFRC has developed a catalog intending to facilitate procurement of suitable items with standardization. The standardization in relief materials is intended to facilitate field operation and support logistics, improving quality of insurance, communication and reporting. It would also avoid inappropriate donation. Their catalog provides generic technical specification for essential items. The catalog provides guidance and assistance to the first operation requesters, operation users and decision maker, and also donors and national authorities concerned with planning, budgeting and execution of assistance programs in emergency situation. The second one is the purchaser and supplier involved with the supply of emergency item. The catalog classifies product in the following product group. First one is warehouse and administration, second relief and logistic kits, ERU or RDU, personal security equipment, radio and telecommunication, power supply and electrical equipment, tools and hardware, foods, household, shelter and construction material, livelihood, vehicles and consumable, water and sanitation, drugs, product, medical disposable supplies, medical equipment, cold chain, laboratory, physical rehabilitation, basic health care ERU, emergency care and triage, rapid development emergency hospital, referral hospital ERU, surgical hospital weapon wounded, medical kits, feeding and nutrition kits, medical sets, surgical instruments and sets, The Sphere Handbook of Humanitarian Charter and Minimum Standard in Humanitarian Response is one of the most widely known and internationally acknowledged set of common principle and universal minimum standard in life-saving area of humanitarian response. Sphere Handbook is broadly accepted by the humanitarian sector and is followed in the humanitarian response. The Sphere Handbook put the right of disaster affected population to life with dignity and to protection and assistance as the core of humanitarian action. It promotes the active participation of affected population as well as of local and national authorities and is used to negotiate humanitarian space and resource with authorities in disaster preparedness work. The handbook provides ethical and legal backdrop to the protection principles as well as to the core and minimum standards, thereby setting the stage for appropriate interpretation and implementation. Founded on the principle of humanity and the humanitarian imperative, these include the right to life with dignity, the right to receive humanitarian assistance, and the right to protection and security. The Charter emphasizes the importance of responding agencies' accountability to affected communities. The core standard and minimum standard are articulation of what these principles and obligations mean in practice. The minimum standards cover 4 primary life-saving areas of humanitarian aid. First one is water supply, sanitation and hygiene promotion. Second, food security and nutrition. Third is shelter, settlement and non-food items. And the fourth one is health action logistic strategies. Many logistic strategies for relief supply chain have been proposed based on different parameters. Here we consider disaster logistic strategies based on the time and location based disaster classification. Disaster may be classified based on a combination of geographic dispersion and speed of onset. Based on this, different logistic strategy for each classification is identified. Dispersed and sudden onset. These type of disaster tend to the most catastrophic because of the lack of warning because onset and the large geographic area covered. These disasters span over nation and require international assistance. Severe capacity constraints on flow of inbound supply arises after these kind of disaster, which is we have seen in the case of Indian Ocean tsunami. Localized and sudden onset create difficulties lesser than dispersed and sudden onset event but still overwhelms the local capacity. These are limited to the national or regional boundary. These sudden events do not provide time to prepare for the event. The situation gets worse if pre-existing socio-economic and institutional vulnerability exists, which is in the case of Haiti earthquake. Localized and slow onset. These type of disaster provide preparation time. They are also limited to regional or national boundaries. Compared to the other 4 categories of the disaster, these are the easiest to address, but even these events can affect significant number of population due to poor planning and infrastructural failure post-disaster, which is in the case of Hurricane Katrina. The fourth one is dispersed and slow onset. When a disaster is slow but a significant area is affected, it requires substantial planning, resource allocation and coordination between the different actors. Though slow onset disaster provide lead time, planning and effective implementation of the plan become crucial, which is in 2009 influenza epidemic. Based on the type of disaster, 4 fundamental strategies can be employed. The first one is prepositioning. It is the most desirable logistic strategy for disaster event where it would shorten the lead time to provide supplies. But the primary issue with the prepositioning is investment in such inventories could be large. Store of prepositioning stock should be secure, else prepositioning is ineffective. The second one is proactive deployment. Mobilizing material in areas close to expected disaster zone when a disaster is anticipated. This reduces delivery time but is less effective in lead time reduction than prepositioning. But this reduces cost involved in holding inventories. Third one is phased deployment. It is the delivery of material to a disaster area as it is needed and in the quantity in which it is needed. It prevents inundation of disaster affected areas by unsolicited materials. Fourth one is surge capacity. It refers to surge in transportation of manpower and material from location outside disaster zone once a disaster strikes. It is comparable to prepositioning of capacities. Prepositioning as a strategy. It is the process of placing essential supply at a strategic location before a disaster event occurs so that they may be available immediately after the event. Positive strategy. Key commodities are available in short time reduction in lead time, increasing speed of response. Commodities are accessible because of strategic geographic positioning. Goods available at right price through prior negotiation. Extra cost of purchase post-disaster due to high demand can be avoided. Helps in maintaining the quality standards, safety against emerging threats, aids decision making and emergency planning when information of available stock is known. Negative strategy. High cost involved in purchase and maintenance, expiration of unused materials and issues with disposal, hard to receive funds pre-disaster to support large inventories, post-disaster financial relaxation are not applicable in pre-disaster purchase. In multiple cases, it has been observed that pre-positioning of materials have been largely successful in quick response. The concept of pre-positioning is embedded in military planning operation. The success of IFRC response in Uganda was largely attributed to decentralized supply chain and its pre-positioning strategy. Even in Cyclone Nargis in Myanmar, the pre-positioning approach helped. India is a multi-hazard prone nation with multiple regions affected by disasters, both routine and rare. In case of routine hazard, the response is often more costly than preparedness, and also the certainty factor is also high. As such, prepositioning in this case should be considered. In case of rare hazard, uncertainty and magnitude is often a hindrance to design a prepositioning solution. But if the correct prepositioning strategy based on the product type and disaster location is used, then the negative of prepositioning can be suitably handled. Now we will discuss about post-disaster healthcare management. Both on the above understanding, let us look at the post-disaster healthcare management. In this section, we will focus on public health and explore how public health issues in disaster can be addressed. Public health is an effort by the society to protect, promote, and restore health of the community. It is a combination of sciences, skills, and belief directed at maintaining and improving health of the people through collective social action. It aims at preventing diseases and addressing health needs of the population as a whole. The following diagram shows the threefold mechanism of healthcare intervention. The people standing near the cliff are marching ahead. Without any protection, they might walk off the cliff, fall, and may be seriously injured. Through the health interventions, the primary barrier is erected at the cliff so that the people do not walk off the cliff. Then a secondary prevention mechanism is laid in the form of a safety net, and thirdly, as tertiary prevention medical care is present at the ground to provide medical assistance in case of a fall. Now we will discuss about public health approach. The public health care approach to the community dwellers follow the following steps. First is define the problem, collection, analysis and interpretation of data. Second, identify the risk, whether preventable, controllable, what is the priority. Third, identify the protective factor and prevention strategy. Fourth, identify the implementation mechanism and widespread adoptions. The key challenges that public health faces due to disaster include: the first one is exposure to natural elements, which is massive displacement and homeless might result from disaster. This becomes a particular problem when disaster occur in areas with extreme temperature or weather, which is an example of Pakistan earthquake of 2005 ravaged village, leaving many homeless. Providing sufficient provision to avoid the impact of the upcoming winter was a major concern. Second is food and nutrition. Shortage of food in the aftermath of a disaster due to the availability or access constraint put affected population under severe stress. Malnourishment, energy deficiency, reduced immunity are some of the major issues faced. Protein energy malnutrition, which affected children in poorer communities in most of the developing nation, increases susceptibility to many communicable diseases like malaria and tuberculosis. Fourth is communicable disease. The risk of diseases, especially communicable disease, in a post-disaster scenario is dependent on the following factor. Pre-existing diseases in population. The risk of epidemic after a disaster is related to the endemic level of diseases pre-existing in the population. These include various diseases like diarrhea, dysentery, cholera, measles, tuberculosis, malaria, skin diseases and relapsing fever. Diseases caused due to ecological changes. Natural disaster may alter the potential for diseases transmission by altering the ecological conditions. Most important diseases are those transmitted by mosquito vector and through water. The breakdown in living condition following disaster may increase the hazard of transmission of such communicable diseases. The incidence of dog bite and risk of rabies may increase as neglected strays come in close with contact with person living in temporary shelters. Population movement. Increased population density in disaster affected area may cause burden on water supply and other services. Further, the movement could also introduce susceptible population to a new disease or disease vector. Few of the potential disease outbreak in the temporary settlement are diarrheal disease and dysentery, viral hepatitis, measles, whooping cough, malaria, tuberculosis, scabies and other skin infection. Damage to the public utilities. Damage of water supplies and sewage disposal system may increase waterborne and excremental diseases. Interruption of public health services. The important services interrupted in this context are vector control program, which might lead to resurgence of malaria and other vector-borne diseases. Routine immunization program against measles, whooping cough, poliomyelitis, tuberculosis and diphtheria may also be interrupted. Social reaction, which include spontaneous behavior like panic and anxiety. Thus, a thorough understanding of the situation including the disaster and its corresponding impact on vulnerable population, the adaptive capacity and the catastrophic destruction of adaptive capacity would help in providing life-saving medical care and preventive health care due to disease spread there, aiding in early recovery process. Once the immediate response starts to bring stability in the health of the disaster affected community, emergency health care must give way to a public health focused response for sustainable long-term arrangement. Depending on the type of impact, health management processes post-disaster would consist of the search, rescue and first aid consist of searching for the rescuing the affected people, providing physical and psychological first aid. Triage. If the quantity and severity of injuries is greater than the operating capacity of health facilities available at the site of disaster, a rapid classification of the injured on basis of severity of their injuries and likelihood of their survival with prompt treatment is envisaged. Such a practice by medical professional is termed as triage. The following four color code system is utilized. First one is field care. The provision of healthcare facilities at the disaster sites including hospital bed, medical and surgical services along with the trained medical personnel to effectively respond to the demand. Let us discuss the guideline to address public health in post-disaster situation. First one is implement public health measure at the earliest after any disaster event so that the risk of disease transmission may be reduced. Second, organization of a reliable and robust disease reporting system to identify outbreak in disaster affected area and to promptly initiate control measure. Third, disease surveillance mechanism to be established to investigate all report of disease outbreak rapidly with a special focus on communicable diseases through water, air and other vector-borne diseases. Fourth is nutrition. Infants, children, pregnant and lactating women, sick people's need must be taken care of in priority. nutritional need of the affected population, their daily food ration must be calculated and a step must be undertaken to ensure food relief by monitoring the nutritional status of the affected population. Fifth, kitchen sanitation and personal hygiene of individual involved in food preparation must be maintained. Sixth, water supply. Survey of water sources and distribution system must be undertaken at the earliest to gauge their physical integrity, remaining capacity, bacteriological and chemical quality. The need for chlorination and other purification efforts must be met. Sanitation effort must ensure waste and excreta disposal occur at a safe distance from water source. Seventh, sanitation and hygiene effort must also ensure that safe washing, cleaning and bathing facility are available. Emergency latrines are set up and efforts are channeled toward intensified vector control program. Now, we will summarize this module as the relief requirement in a post-disaster operation can be segregated in 4 distinctive phases: assessment, deployment, sustainment and reconfiguration. Supply chain in disaster specializes in organizing the procurement, transport, storage and delivery of required supplies in case of disaster to the affected people. Prepositioning is the process of placing essential supply at a strategic location before a disaster event occurs so that they may be available immediately after the event. In multiple cases, it has been observed that prepositioning of material have been largely successful in quick response. Public health aims at preventing diseases and addressing health need of the population as a whole. A thorough understanding of the situation, including the disaster and its corresponding impact on the vulnerable population, the adaptive capacity and the catastrophic destruction of adaptive capacity would help in providing life-saving medical care and disease spread preventive health care, thereby aiding in the early recovery process. Thank you.